The next session is 2UU session. Who won the Nobel Prize in Physiology or Medicine 2015 for her discoveries concerning a novel therapy against malaria. And for this session, we have the chairperson with us, Dr. Madhav Desai sir from Ahmedabad and Dr. K.N. Bhatt sir from Surat. I welcome you, sir, and I request Dr. Madhav Desai sir to introduce our first speaker.
It's indeed a great pleasure to introduce Dr. Yajnik sir. Everybody knows him surely, and whenever you think of YY products, the name that comes up from India is Dr. Yajnik. He has a tremendous work in the field of GDM, and he is from KEM Institute of Pune, and we'll better learn more from him about the controversies in GDM. Over to you, sir.
Hello. Nice day to everyone. Thank you, Mayur. Thank you, Mona, for inviting me. I have chosen a topic which is slightly controversial. It's, you can say, either the controversies in the GDM, or slightly more provocatively, I can say, does GDM exist? As I'm very proud of saying, I am the sort of director of the KEM Hospital Diabetes Center in Pune. And also proud to say that this is the only diabetes center in the world which has mother and baby as the logo. And that has bearing on the topic today. So gestational diabetes is defined as diabetes diagnosed during gestation. What I'm going to try and raise is, are we sure it's only gestational? And do we really know what is this diabetes? And if we look at the concept of GDM as it evolved over last more than 50 years, then some of the things will become apparent. So originally when O'Sullivan and Mahan described GDM, it was criteria for pregnancy glycemia, which was associated with later diabetes in the mother. So it had nothing to do with the pregnancy. As the time went, people realized that these glucoses or glucose cut points were also associated with some of the pregnancy outcomes, either short-term maternal or fetal neonatal outcomes, which we broadly call pregnancy complications, and also, as they had originally planned, with long-term risk of diabetes in the mother. And as we found out later on, long-term risk of obesity, diabetes, and cardiovascular disease in the children. This was how things were till WHO and others came into picture in 1985 onwards, and they defined GDM as anything which was non-pregnant IGT or mild diabetes. They had no outcomes in mind at all. Then came the HAPO study, which predominantly looked at macrosomia-related outcomes. That's the size of the baby above the 90th centile, or the C-peptide in the cord blood, or cesarean section rate. So they were all related to big babies. Real issue is that if we use this criteria and diagnose women as GDM, then we know that there are some outcomes which are either short-term or long-term. But by treating GDM, are we really able to prevent any of these? And ultimately, we don't have time for that. We have to think how much of this is genetic, how much of it is epigenetic, because epigenetics is something which you can modify. Genetic is something which, at least in theory, you cannot modify. I've been thinking like this not only today or yesterday, even in 2010, Diabetes Care invited me to write an editorial, and I had written this editorial called Fetal Programming of Diabetes, Still so much to learn. And that time I had raised the question, is GDM a de novo diabetes of pregnancy or is it something else? What is its life course trajectory? When does it begin? How does it progress? Then, of course, the perpetual question, whether glucose, is it the important nutrient? But probably not, because maternal lipids, amino acids, micronutrients also have effect on fetal growth and programming. There's also the issue that insulin resistance drives gestational diabetes. And in a malnourished population, actually insulin resistance in the mother may be a mechanism to maintain fetal growth. And provocatively, again, we have to think, do malnourished mothers have to be more insulin resistant to produce good-sized babies? I'm not going to discuss this today because it's a separate and very interesting topic on which we have a lot of provocative data. And finally, very importantly, have our efforts to treat, diagnose and treat GDM reduce the offspring diabetes, whether in the short term or in the long term. So the workshop which was held to define and propagate GDM defined it irrespective of whether or not insulin is used for the treatment, or if the condition persists after pregnancy, we call it GDM, but they very wisely said it does not exclude the possibility that glucose intolerance may have antedated the pregnancy. And that means there was some knowledge that our GDM definition may not be the correct one. And as you know, many of us diagnose type 1 diabetes, type 2 diabetes, pancreatic diabetes in pregnancy. Do we call it GDM? And we also have to think what happens after the delivery. And in all these issues, we have changed the goalposts from time to time whenever convenient. So I'm going to raise 3 questions and answer them. Is GDM gestational only? And idea that it's only gestational came from this Norbert Frankel figure in 1980. He was a great man who did a lot of research in pregnancy diabetes. But I think where he probably didn't do well was he actually thought GDM started somewhere in the later half of pregnancy, as opposed to pre-gestational diabetes, which was there from before pregnancy. And today we will see some evidence that this may not be true. The interest in gestational diabetes or diabetes in pregnancy was propagated very much by Pima Indian research, which showed in 1980s that babies born in a diabetic pregnancy had higher risk of obesity and higher risk of diabetes in later life. And we need not go into details of their analysis, but bottom line is that they showed that exposure to glycemia in the pregnancy, rather than the genetic transfer from the mother, was responsible for this connection with obesity and diabetes. But very importantly, when I spoke to investigators of Pima Indian studies, they said majority of diabetic pregnancies were pre-gestational. It was not gestational diabetes. And then Pat Catalano, the great sort of thinker in this area, and whose research has driven most of the metabolic thoughts in gestational diabetes, showed that women whom he studied from before pregnancy, in early pregnancy and late pregnancy, those who he diagnosed later on as GDM, had a series of metabolic abnormalities and obesity from before pregnancy. So very clear demonstration. Then I found out this reference from the Kaiser Permanente group in California. They were reporting that those women who were diagnosed as GDM had an adverse pre-pregnancy lipid abnormalities. And while writing the paper, they completely overlooked that these women actually had family history of diabetes. Their pre-pregnancy BMI was higher. Not only that, their glucoses were higher, their cholesterol, HOMA-IR, insulin, everything was higher. In other words, all the metabolic abnormalities which you call gestational diabetes were present from before pregnancy. In other words, it was pre-gestational. We have done the Pune maternal nutrition study in 6 villages near Pune to find out what are the determinants of fetal growth in the rural Indian women. And we also followed up the children born in this study 25 years earlier to find out how their diabetes risk evolves. And for this, I have to tell you that we admitted or enrolled more than 800 pregnancies in 1993 to 96. We've measured the mother, the baby, and the father during pregnancy. We measured the delivered baby at birth, and we have followed them up every 6 months for growth and every 6 months for metabolic studies ever since. And now we are into 24 years of follow-up. And we have a biobank. So at 18 years of these children, we found that almost a third of them had pre-diabetes, 28.7%. A lot of them had IFG, many of them had IGT, and 2 had diabetes. And the whole prevalence of high glucose was more in boys than in girls. When we looked back at their glucoses, which we had measured at 6 and 12 years by glucose tolerance, we found a remarkable thing. That glucose at 18 years, or glucose intolerance at 18 years, as defined by AIIDR criteria, was strongly predicted by their glucose at 6 years of age or at 12 years of age. You can see here, higher the glucose at 6 years, higher is the risk of glucose intolerance at 18 years. Higher the glucose at 12 years, higher is the risk of glucose intolerance at 18 years. It was 2.5 times and 4 times higher if you belong to the highest quintile compared to the lowest quintile of the fasting glucose. In other words, the metabolic abnormalities were tracking. They were tracking so strongly that you could predict with reasonable certainty what will be their glucose in later life. And we did multivariate analysis and found additionally that mother's pregnancy glucose was an additional predictor of child's glucose at 18 years. And for the female participants, father's glucose was also important. So that's quite a remarkable finding, that we can measure at birth or at 6 years certain things and predict what is the glucose in later life. And then the girls in this study are now getting pregnant, are now getting married and pregnant. And that actually told us something even more, because what we can now say is that when that girl becomes pregnant, we do her OGTT, we can relate it to her glucose at 18 years, 12 years, 6 years, and a mother's glucose in pregnancy. And we have drawn a very nice figure of tracking. If we look at the daughter's glucose in pregnancy at 18, 12, and 6 years, there is such a strong tracking of fasting glucose from pregnancy back into the previous life, and even into maternal glucose during the pregnancy, so that when this girl was growing in a mother's womb, higher the glucose in the mother, higher was the glucose in the child during her pregnancy. I don't think any other study in the world can show this. We are able to show it because we have very good follow-up. And then we could find that the babies born to the daughters are about 250 to 200 grams heavier compared to their mother at birth, because we have all these measurements. And that was contributed by larger size of the mother, that means higher BMI, which is only 1 unit higher glucose of the mother in pregnancy, higher lipids in the pregnancy. So it suggests that actually intergenerationally, as the daughters have grown better than their mothers because of the better socioeconomic conditions, they have higher glucose and they produce bigger babies. So this is all intergenerational, and we can't say this is only gestational. Is the diabetic threshold which we use in pregnancy the correct one? Do we really know that? So HAPO, which is the mother of all studies for the current thinking of gestational diabetes, very clearly showed that all the 4 outcomes which they studied, like birth weight, the cesarean section, neonatal hypoglycemia, or the cord C-peptide, were continuously associated with maternal glucose right across the range. Higher the glucose, higher the outcome. But it's not that suddenly somewhere here things go wrong. There is no inflection point. So this is very important to understand, that association between maternal metabolic measures and the baby's outcome are continuous. And when they studied the children born in this study, 10 to 14 years old, again, all the outcomes of glucose intolerance and the obesity which they had studied were continuously related with maternal glucose in pregnancy. No cut point where you can say diabetes had occurred. So the current AIIDR criteria are based on larger baby-related outcomes, LGA. There is really no diabetic threshold. So they appointed a committee and a statistical arbitration was used to define the cut points where we call them GDM. I think that is not very satisfactory at all, and it can create a lot of confusion. And within 1 year of publication of AIIDR criteria, number of European countries said we don't want to use this, we will have our own criteria. So today there are multitude of criteria across the world just telling us we don't know what is really gestational diabetes. Another side of the story in which I am very interested is that low birth weight, certainly in India, is a risk factor for future diabetes. Remember, the HAPO criteria are all based on larger birth weight. While in India, the major problem is actually low birth weight. India is world's low birth weight capital. Even today, 25% of babies born in India are low birth weight. And India is, of course, capital of diabetes. And you know from our research how these two are connected through fetal programming. We are not going to get into that. But therefore, keep in mind that the type of macrosomia which HAPO study used to define the criteria really doesn't exist in India. Lois Jovanovich, who was one of the most celebrated worker in pregnancy diabetes. Unfortunately, she is no more. Here you can see when I visited her, we became quite good friends. So she said, actually, she wrote this editorial, Confessions of an Old Dog, because towards the end of her career, she realized many things about which she had fought may not be actually correct one. So just let us read the last paragraph. She said, I never imagined that the strategy to ignore maternal glucose in women who are carrying fetuses predisposed to intrauterine growth retardation and thus allow maternal hypoglycemia to remain untreated in order to encourage more accelerated fetal growth would be added to this list. So what she said was she had completely misunderstood the requirement of pregnancies where babies were intrauterine growth retarded, and therefore she really admitted, and we had very good correspondence on this. So finally, we have to see what good we do by diagnosing and treating gestational diabetes as we do today. So this is a trial done in United States. It was a randomized controlled trial of treating gestational diabetes intensively against the conventional treatment of GDM. And when they studied the children, when they were 10 to 14-year-old, what they found was they had not prevented obesity, they had not prevented hyperglycemia in the children. So despite all the efforts at intensive control of glucose in pregnancy, they were not able to modify the risk of adiposity, obesity, and glucose intolerance in the children. This is a very good evidence to say that what we do in clinical practice achieves probably something in the short term, but nothing in the long term. And this is a follow-up in my department. 200 children born to diabetic mothers treated quite intensively because we are a diabetes unit and I'm interested in this for a long time. So we treat them as per the guidelines. But when we studied them 10 years later, 5% of these children at an average age of 15 years had diabetes, 37% had prediabetes. So our intensive treatment had really not prevented the outcomes which we would like to prevent. Therefore, the diabetes epidemic is actually propagating. So Pat Catalano, who has thought about this quite a lot, wrote this article in 2014 saying, trying to understand gestational diabetes. So let's read what he said. He said, although gestational diabetes is most often diagnosed in late gestation, the seeds of metabolic dysfunction are planted well before conception and possibly based on Barker hypothesis when the woman herself was developing in utero, like I showed you in the PMNS study. Therefore, he says, achieving optimal metabolic health before a planned pregnancy may offer the best, but not necessarily the easiest option to achieve a healthy pregnancy outcome, short-term and possibly a long-term as well. So there was another epidemiologist in England who, like typical humor in England, said in 1980s and 90s that gestational diabetes is no more than a special case of impaired glucose tolerance temporarily associated with pregnancy. So he said long time ago that we are rediscovering diabetes in pregnancy when we do their glucose testing. So in summary, gestational definition and criteria have changed frequently. That in itself should warn us that people just don't seem to know enough. So-called gestational metabolic abnormalities are present from early life. We have no good idea what outcomes we are trying to prevent. Macrosomia-based criteria need review in a country where LBW is the major problem. And only thing which can help us will be sensible research. And I hope you join me in propagating such sensible research. I'm just going to show you a cartoon. Many of you have probably seen it. So a policeman finds a man looking for something under a street light. So he asks him, did you drop something here? So he says, I'm looking for my quarter which I dropped. Quarter, as you know, is a small coin. So police asks, where did you drop it? So he said, no, I dropped it 2 blocks down the street. And then police says, why are you searching for it here? So he says, because the light is better here. So this is a sort of a situation for gestational diabetes. The coin has been dropped intergenerationally. We are trying to diagnose it in late pregnancy and trying to treat them. We really need to go back and find out what we can do from the origin. Thank you very much.
Thank you so much, sir. It was pleasure to hear from you. I request Dr. Madhav, sir, if you want to say something to this.
Yeah, as expected and as usual, Yajnik sir, you are absolutely on the dot. And had it been in the audience, I'm sure we would have the standing ovation. Thank you so much, sir.